We have three wonderful speakers again this afternoon. And I will start by introducing the first one, Dr. Mercedes Bernadá. She's an associate professor of pediatrics and the director of the Pediatric Palliative Care Center in Montevideo, Uruguay, and she's going to talk to us about gastrointestinal symptoms.
Wow, thank you.
Sorry, let me just say something I forgot. If you want to write your questions and pass them on to the table, it's probably easier because sometimes people have been complaining that they don't understand what's being said at portable microphones. So if you want to do that, please. And we will take questions after each of the talks.
Thank you. Would you... Thank you. Well, good afternoon. As Anna said, I am a pediatrician from Uruguay, and it's a great pleasure for me to be once more in this amazing city and meeting with you. At first, I especially would like to recognize and congratulate and thank Maruzza Foundation and Silvia Lefebvre and Franca Benini for making it possible. I have no conflicts of interest, and the pictures included in this presentation were authorized by the children and their parents for their exclusively educational purposes. Uruguay is a small country in South America, opening to the Atlantic Ocean between Argentina to the west and Brazil to the north. This is my hospital, and the other pictures are from different places in my country, which I would like to show you in person someday. I need to clarify that for the sake of this presentation, I will indistinctly say gastrointestinal symptoms or problems, in spite of not being exactly the same. My main objectives for these 20 minutes will be to describe the prevalence of gastrointestinal symptoms or problems, to apply a general pediatric palliative care symptom management framework to a frequent gastrointestinal symptom, and to reflect about gastrointestinal symptom management challenges in the context of the general child's plan of care. It is well recognized that gastrointestinal problems are common when addressing distressing symptoms in pediatric palliative care. But currently, it's not possible to determine a unique prevalence estimation. It varies very much regarding the clinical condition of assisted population and the phase of life, among other variables. In this amazing study, known by almost all of you, Sean Wolf and collaborators found that either during follow-up, as at end of life, a significant number of children with cancer expressed discomfort related to gastrointestinal symptoms like nausea, diarrhea, vomiting, constipation, and dysphagia. In this other collaborative research from the US, Chris Furner and authors showed that the most prevalent chronic complex condition categories was gastrointestinal, which is important data for the current topic. In addition, when analyzing the 20 most frequent symptoms reported by parents, 6 of them were gastrointestinal, such as diarrhea, vomiting, constipation, difficulty in eating and swallowing, and mouth sores, as you can see in the chart. And in this descriptive study we presented yesterday, which was carried out during 2020 in Uruguay, including data from 14 pediatric palliative care teams in the country, we found that 96 out of 436 assisted patients had gastrointestinal symptoms, which determined 114 consultations during the study period. And what most surprised us was that swallowing and feeding disorders were the most frequent gastrointestinal problems referred to. This may be probably because the most frequent healthcare conditions found were the ones included in the ACT group 4 and very few children with cancer. As for the second objective, this is the general pediatric palliative care symptom management framework that I am going to apply this afternoon. And the symptoms I select to address are feeding and swallowing disorders. And I selected these problems because, as I can see, it is an increasing and common problem, but poorly visible and not frequently seen as something to address from the pediatric palliative care perspective. Secondly, because feeding and swallowing disorders may be the problems themselves, but may be the mask of other very frequent problems in the population assisted by pediatric palliative care teams. And last but not least, because it is a very distressing symptoms that affect the quality of life either of patients and carers, and thus represent an important burden for all of them. When someone thinks about swallowing disorders, what firstly comes up are problems at any of these swallowing phases. And these are some of the most frequent symptoms that children present when they have swallowing or feeding disorders. But regarding the causes of swallowing and feeding disorders in most of the children, they are multifactorial, resulting from the confluence of any of some of these comorbid disorders. Neurological and neuromuscular disorders, by different mechanisms, interfere with the complex coordination of sensory and motor functions necessary for a safe and complete feeding and swallowing. It is said that the prevalence of feeding disorders in this population may be as high as 90% of children with neurological conditions, and its severity correlates with the severity of motor impairment. In addition, children with tracheostomy and children with airway malformations who underwent other airway surgeries have great predisposition to these disorders as a consequence of altered pressure system and loss of sensitivity of the larynx, amongst other mechanisms. There is also increasing evidence that children with many other life-threatening conditions may have visceral hyperesthesia for many reasons. For example, children with abdominal surgeries and prolonged tube feeding, but also children with severe congenital cardiopathies with long stays in the ICU and multiple distressing oral procedures. And from a comprehensive analysis, I cannot stop mentioning the relevance that concurrent psychiatric and psychosocial tough problems that these already tired and overwhelmed parents may be facing while trying to help their children in the process of acquiring oral feeding and in a great way interfere with it. For this journey, I would like to share with you the story of a beloved Uruguayan patient, Sofia, who nowadays is a 13-year-old adolescent, but at birth was diagnosed with a classic transposition of the great vessels and operated on at 26 days. In the postoperative period, she underwent cardiac and extracardiac complications, which determined a long stay in ICU. There, she was fed by a nasogastric tube, and after recovery, she had a complete oral feeding aversion. So, at 5 months, an endoscopic percutaneous gastrostomy was put, which allowed enteral feeding until 13 months, when it could be withdrawn. It is proposed that long ICU stays and very frequent severe neonatal or infant pain experiences and distressing oral procedures as orotracheal intubation, mouth and nasal suctioning, tract aspiration, among others, determines strong peripheral nociceptor sensitization and central nervous system arousal activation with the subsequent oral discomfort, odynophagia, dysphagia, dyspepsia, and early cessation and food refusal. And there is increasing evidence that gabapentin may improve the voluntary oral intake by reducing oropharyngeal discomfort associated with feeding. And this is being called a pain rehabilitation model. All these studies included children with various different clinical conditions as severe neurological impairment, complex congenital cardiopathies, and children with abdominal surgeries. All of them had oral feeding intolerance expressed by retching, food aversion, poor intake, poor weight gain, and multiple complications related to alternative nutritional ways. All of them have failed to non-pharmacological and pharmacological measures tried, and for different mechanisms, in all of them, visceral hyperexesia was thought as a possible cause of feeding refusal and discomfort. So, gabapentin was tried with significant success, mainly shown by the resolution of retching and oral food aversion. We acknowledge this is not strong evidence, but is the one available so far, and perhaps any of us may propose a better methodological research regarding this topic. So, as for the general pediatric palliative care symptom management framework for this particular gastrointestinal symptom, anticipation means to recognize each of the situations you see on the slide, as they represent high risk for the development of feeding or swallowing disorders. And you may agree with me that some of these conditions are frequently present in most of the children assisted by pediatric palliative care teams. Prevention is another important task of pediatric palliative care. And for these particular symptoms, prevention is also possible, and from the interdisciplinary team working perspective, early inclusion of speech and language or occupational therapists with training in swallowing disorders and embedded in the pediatric palliative care philosophy is the hallmark of dysphagia prevention. Here it is. The comprehensive assessment in this case means a detailed clinical history looking for signs of feeding issues like the ones you see on the slide. And according to the clinical finding, complementary studies may be done as pertinent. As for multimodal treatment, it must include non-pharmacological measures as the high participation of speech or occupational therapists for workout and rehabilitation, as we already said, ample emotional support for children and parents, and education is needed to prevent the onset of behavioral feeding problems or to resolve the already installed ones. Other needed measures in occasions are tube feeding considerations and changes in diet consistencies. And among pharmacological treatments, gastroesophageal reflux disease treatment may contribute to abdominal and feeding tolerance, and a trial with gabapentin may be considered as shown. And as always, in pediatric palliative care, none of these is possible without an interdisciplinary team working. Monitoring means active follow-up by interdisciplinary team, not just saying to the parents, call if you need anything, as was found by Requena and collaborators in this amazing research. Monitoring feeding or swallowing disorders means active follow-up of these particular items, particularly child comfort. And of equal importance, the registration of the chart is a critical task on pediatric palliative care professionals in order to ensure continuity of care, but unfortunately is frequently forgotten, as shown by Stefan in this pain research. Regarding the last objective, I will do it with the help of other two beloved patients. Tiago was a boy with a 13 trisomy who lived until last year when he was almost 13 years old. As a consequence of his severe neurological impairment, Tiago had significant feeding problems. Once his parents told me that they had decided to take his boy to the US to put a gastrostomy tube. Sincerely, at first, it appeared to me quite disproportionate, as this is not a complex procedure and pediatric surgeons practice it quite frequently in my country. But they explained to me that from other parents, they heard that in Uruguay, postoperative complications were frequent, and through conversations with the surgeon, they realized that this was mainly a consequence of the lack of all the full range of sizes of gastrostomy buttons that in the US have, resulting in increased possibility of milk and gastric content leakage, among other complications. Tiago's story taught me many things along his span life, but one of them is the significant differences that may come up regarding the same procedure in different settings. And Uruguay is not the poorest country in the region, but this is one among many other sources of inequities in pediatric palliative care quality among regions in the world, and should be taken into account when making clinical decisions. Luca is another dear patient that always traveled with me in my soul. He was an 11-year-old boy with a chronic non-progressive encephalopathy secondary to complex brain malformation. Despite having severe disabilities, according to his mother, he had a quite good quality of life. Until his 10 years, he was orally fed with puree consistency food, and along his span life, he had only 2 admissions for respiratory infections. At the age of 11, the medical team insisted his parents to feed him firstly through a nasogastric tube and afterwards through a gastrostomy tube, which was performed by Nissen technique. On the postoperative period, he had a suture failure, peritonitis, sepsis, and many reinterventions. His parents refused to continue with surgical interventions, what determined strong arguments among the healthcare team. So, from the ICU, the pediatric palliative care team was called for the first time. Parents were listened to, goals of care were set, aligned with parent values, and advanced care planning was carried out. Luca was discharged home with subcutaneous medication, where he passed away peacefully some days later. And what could be done different for Luca? Nothing more suitable than the main message of this conference: listen, really listen. And as for the last step of the pediatric palliative care symptom management framework, I would like to emphasize the importance of the alignment to goals of care. Goals of care are the common thread of all actions in pediatric palliative care. It means to very exactly define the disease trajectory stage, but mainly to listen to patients, parents, or other caregivers to learn about their wishes, perspectives, and values. There is the need to clearly identify and distinguish between our professional identification of problems, malnutrition in Luca's case, and patients' and families' needs. And there is also the need to understand the process previously done by the family, the decisions made or needed. and with all that information to elaborate an advanced care plan, which includes the symptom management plan. Goals of care are the light that illuminates and guides all the pediatric palliative care interventions while planning the prevention and treatment of any distressing syndrome, and they should be revisited periodically. So, as conclusions, I would like to point out that gastrointestinal symptom prevalence varies according to the population and disease stage. We highlighted feeding disorders as very frequent but invisible and perhaps normalized symptoms among children in need of pediatric palliative care. We showed that a general pediatric palliative care symptom management framework can be applied to this problem as well. And we would also like to emphasize that predisposing conditions should be considered for early evaluation and prevention, even in the absence of clear symptoms. Multimodal treatment by an interdisciplinary team must include speech and language therapists and consider the possibility of gabapentin benefit. And for this symptom, as always in pediatric palliative care, comprehensive symptom management should be aligned to stage of disease trajectory, patients' and parents' values, and defined goals of care. I hope that these reflections would help to the comprehensive management of this so frequent and distressing symptom for children and their parents. Thank you very much.